Hello everyone, this is Townsend Reeves. Today I'm going to be talking about ultrasound-guided nerve blocks in the emergency department. In particular, we're going to cover two hip blocks, and I think this is a really important topic, in particular because we see a significant number of low-energy traumatic hip fractures in our elderly population here at Aventura. And these regional anesthesia techniques, these ultrasound-guided nerve blocks, are really becoming the standard of care, the standard of practice within emergency medicine, and they're becoming increasingly more prevalent and utilized across the country. So I think it's important that we know how to use these techniques and when to use them. So without further ado, let's get into the lecture. These are our learning objectives for the lecture. First, we're going to understand the critical role that these ultrasound-guided nerve blocks play in a multimodal pain management paradigm within the emergency department. We're going to talk about the basic supplies that we actually need to perform these blocks. We're going to detail local anesthetic selection based on a desired duration of blockade, how to recognize and treat the feared complication that comes along with performing these blocks, and that's local anesthetic systemic toxicity, or LAST. We're going to dive into two readily available and important lower extremity blocks, the Fascia Iliaca compartment block and the Periencapsular nerve group block. And then lastly, I'm hoping I'm going to be able to convince you as to why you should be performing these blocks as a part of your emergency medicine practice in managing acute pain. So I'm going to start the lecture with asking the question, why do we care? Why should I be performing ultrasound-guided nerve blocks in the ED? Why not just, slam our patients with opioids? They seem to work okay. So firstly, ultrasound-guided nerve blocks and regional anesthesia techniques are a key component of a multimodal pain management strategy. You may say, well, Townsend, IV opioids are easier and they work just fine. And they require less time, and I don't need as much training to administer these. Why are you talking to me about these nerve blocks? In reality, we should be addressing acute pain in the ED with a multimodal pain management strategy. Multimodal analgesia is this idea that we use multiple analgesics, including scheduled Tylenol, NSAIDs, muscle relaxants, PRN opioids for breakthrough pain, regional anesthesia techniques or blocks, and then non-pharmacologic interventions as well, like heating and ice, meditation and mindfulness, for example. And the reason that this paradigm has gained such traction is that there's a great potential, numerous places to intervene along the pain pathway. So Figure 1 details the physiology of pain transmission. So we all remember from med school, we have an acute trauma or insult. This activates the peripheral nociceptors that send pain signals via peripheral nerve up through these primary afferent fibers, and they synapse on the the dorsal horn of the spinal cord, and then they cross over. These secondary fibers cross over at the ventral commissure, and then they ascend in the spinal thalamic tract contralaterally. And these fibers go all the way up, and they synapse in the ventral posterior lateral thalamus, and then tertiary fibers take off from there to send the signal to the somatosensory cortex located in the postcentral gyrus. That's how we sense pain, from peripherally to centrally. And you can see along this pathway that there is a tremendous amount of areas that we can intervene with, with different modalities. So we have local analgesics and anti-inflammatory drugs that act at the nociceptors. And what we're talking about, regional anesthesia or nerve blocks, happen at the peripheral nerve level. There's gating agents, ice and heat, and then opioids and alpha-2 agonists that act at the dorsal horn. And then you have these central acting agents like opioids, dexmedetomidine, NMDA antagonists like ketamine. All these things play a role in adequately addressing an acute pain in a trauma scenario. On the right here, we see the multimodal pain management paradigm across the trauma care continuum. So we see that it highlights that regional anesthesia techniques should be used as much as possible based on patient-specific considerations, and we see that non-pharmacologic therapy Tylenol and NSAIDs, symptom-driven adjuvants like muscle relaxants, etc., and systemic opioids all play a part in dealing with a trauma patient's pain from pre-hospital to discharge. And as the pain severity goes up, you add more modalities to adequately cover their pain. I want to highlight opioids for a second. Opioids, the exogenous ones that we give, they modulate the pain signaling in ascending and descending pathways of the brain and spinal cord. And at the supraspinal level, they act in a similar manner to the endogenous opioid peptide ligands that we have naturally in our body. Additionally, they activate the reward system of the brain within the ventral tegmental area of the midbrain and the nucleus accumbens and the frontal cortex. And that activation has a consequence. It's why they have this dependence and addiction profile. That's why we have this opioid epidemic. So in contrast, the regional anesthesia or nerve blocks, I would argue, because they act at the peripheral nerve, they're more targeted therapies. They're closer to where the actual trauma is occurring. They're longer acting, and they have a drastically more favorable side effect profile. So opioids, have the associated complications of sedation, mental status change, delirium in elderly patients. They can cause respiratory depression, hypotension, nausea, vomiting, pruritus. I mean, the list goes on and on. Furthermore, these nerve blocks, they decrease the pain scores better than opioids. That these patients have better pain relief from these nerve blocks. They reduce the total opioid requirements, and they improve patient mobility and reduce hospital length of stay. So these are all reasons that we should be using these these regional anesthesia techniques. So if you're still not convinced of ultrasound-guided nerve blocks and their utility within the emergency department, our governing body, ACEP, actually released a policy statement in April 2021 on ultrasound-guided nerve block performance in the emergency department. And in it, they make profound statements advocating for emergency physician utilization of these nerve block techniques, such as, they're a core skill which emergency physicians are capable of providing to patients. They greatly benefit patients presenting in pain to the ED. They've been associated with improved post-surgical functional outcomes, decreased delirium, and decreased length of stay, like we've already talked about. And then this last statement is the censure for me. It's the position of ACEP that ultrasound-guided nerve blocks are not only within the scope of practice of emergency physicians, but represent a core component of a multimodal pathway to control pain. There are numerous reasons that ACEP highlights as to why we should be performing these blocks. And then lastly, if I haven't driven this point home enough, the American College of Surgeons actually released a trauma quality program's best practice guidelines in November of 2020 on acute pain management in trauma patients. And within their best practice guidelines, they highlight regional analgesia, these nerve block techniques, as a best practice in management of trauma patients. They recognize that it's an integral component of a multimodal analgesia practice. And they support the widespread implementation of ultrasound-guided nerve blocks in the emergency department. And they actually suggest, creating these prearranged block bags to help eliminate time and availability barriers to performance, as well as institution of policies and procedures governing performance of these blocks. So I think, not only are they advocating for us to be performing these blocks, they're also making recommendations as to how we can eliminate barriers to performance. So I think, between ACEP and ACS, we have numerous support for performing these blocks within the emergency department. So before we cover the specifics of ultrasound-guided nerve block performance, we need to talk a little bit about block basics. So what materials do I need to perform these blocks? How do I select a local anesthetic? Is there a particular way I should set up for this procedure? Things like that. These are the materials needed to adequately perform ultrasound-guided nerve blocks, and this is a pretty comprehensive list. Some points worth highlighting. So firstly, with any procedure, setup is key to ensure optimal performance and to maximize your probability of success. You want to ensure that you have all the necessary supplies readily available prior to commencing the procedure. Perhaps most important to success is utilization of an echogenic short bevel blunt tip needle. So what do I mean by that? So an echogenic needle is one that is readily visible on ultrasound. It reflects the sound waves very well, and it's easier to visualize in an in-plane technique under dynamic guidance, which is critical to avoid inadvertent injury to neurovascular structures or intravascular injection of local anesthetic, which can have devastating complications. A short bevel and blunt tip further reduce the risk of nerve injury or intraneural injection. Your choice of local anesthetic is going to be selected based on desired duration of blockade. So if you're doing a hip block, you'll choose a local anesthetic that lasts a very long time, because this patient is probably going to be going to surgery the next day, and you want to provide adequate pain control that carries them over to their surgery. Whereas with maybe a shoulder reduction and you're blocking the brachial plexus just to pop the shoulder back in, you can choose something that has a relatively short duration, because this is a quick procedure. Ultrasound-guided nerve block should be performed as a sterile procedure. So you're going to need your ChloraPrep applicator or betadine antiseptic solution to disinfect the block site, a sterile ultrasound probe cover and gel, sterile gloves, and then a sterile drape that basically ensures that you're not touching non-sterile field while performing this block. You're going to need an ultrasound machine with a linear array and curvilinear transducers. And then the patient should be placed on non-invasive blood pressure, electrocardiographic, and pulse oximetry monitoring at a minimum. And this is to evaluate for the development of cardiotoxicity, which we're going to talk about later. But this can manifest as a prolonged PR or QRS complex, a tachy or brady, arrhythmia, conduction block, or even asystole. And this is really the result of inadvertent local anesthetic deposition within the vasculature. And then lastly, you want to make sure you have resuscitative equipment, including intralipid 20% solution, readily available at the bedside in case we have a case of local anesthetic systemic toxicity that arises. Let's talk about local anesthetics for a moment. We're going to do a deep dive into these molecules, these drugs, because we need to know everything there is to know about local anesthetics before we can adequately select one to use in an ultrasound-guided nerve block. Local anesthetics are amphipathic in their molecular composition. And what does that mean? Amphipathic basically means that there is a lipophilic component, being this aromatic ring, and then there is also simultaneously a hydrophilic component of the molecule, being this tertiary amine. And this is really important to how local anesthetics function, because when they're deposited around a peripheral nerve, they have to be able to diffuse through the aqueous media that surrounds these nerves, the aqueous tissue compartment. And that is why we have this hydrophilic component here. But they also have to be able to diffuse through the myelin sheaths of the peripheral nerves and the plasma membrane to get to the voltage-gated sodium channels. And that's where the lipophilic component comes in. The lipophilic component and the hydrophilic component are connected by an intermediate chain. This intermediary linkage is either an ester or an amide, and that determines what class the local anesthetic exists in. So the esters are actually broken down by pseudocholinesterase in the serum, and the amides are broken down in the liver. Another important thing to know about local anesthetics is that this tertiary amine can be protonated and deprotonated to form ionized and unionized forms, respectively. And these two forms exist in equilibrium. And that will be an important concept later in the lecture. So how do local anesthetics work? Well, their mechanism of action involves blocking sodium influx through voltage-gated sodium channels, resulting in inhibition of further nerve impulse propagation. Essentially, they block propagation of pain signals through peripheral nerves by terminating the wave of depolarization. They act not by physically blocking the pore of the voltage-gated sodium channel, but rather by altering the relative stability and kinetics of channel cycling through the resting, open, and closed conformations. Local anesthetics bind to the open channel conformation and stabilize the voltage-gated sodium channel in the inactivated state. This mechanism results in a use-dependent or phasic block that will intensify with more frequent rates of nerve fiber firing. So in a trauma scenario, nociceptive fibers are firing frequently, signaling that there is pain, and local anesthetics have a greater opportunity to bind to open sodium channels that are responsible for propagating these frequent waves of depolarization. The more local anesthetic that is able to bind, the more receptors that get stabilized in the inactive conformation, resulting in termination of pain signaling. Lastly, we need to talk about this concept of differential blockade, which refers to the clinical phenomenon that nerve fibers with different functions have different sensitivities to local anesthetic blockade. Smaller diameter axons are more susceptible to local anesthetic action, as are myelinated fibers. This is due to the smaller surface area coverage of voltage-gated sodium channels that is required to produce blockade. The differential blockade phenomena results in sympathetic fibers being blocked first, followed by pain and temperature sensation, then touch and proprioception, and finally motor function. When the fibers recover from local anesthetic blockade, they do so in the reverse manner. So patients will regain motor function first, followed by touch and proprioception, pain and temperature, and then lastly sympathetic function. This illustration is a beautiful depiction of the structure and organization of the peripheral nerve. The reason I show this figure is that it highlights the three connective tissue layers that compose a peripheral nerve. And those are the epineurium on the outside that imparts mechanical strength, the perineurium, which surrounds nerve fascicles, which are just collections of axons, and then the endoneurium, which interdigitates between individual axons themselves. So when we deposit a local anesthetic perineurally, meaning around the peripheral nerve, these connective tissue layers present barriers to local anesthetic diffusion and action. The local anesthetic will diffuse from the outer mantle to the inner core of the peripheral nerve along a concentration gradient. This results in nerve fibers located in the outer mantle being blocked first. Outer fibers are distributed to more proximal anatomic structures, generally speaking, than those situated in the core. And as a result, this block will evolve from proximal structures to distal structures. Furthermore, the core of a peripheral nerve often consists of motor fibers, whereas the outer mantle is more of a sensory fiber distribution, resulting in sensory to motor progression of a block. We can take this to anatomy to our advantage by using smaller doses and or concentrations of local anesthetic to predominantly block sensory fibers as compared to the motor fibers that are located deeper into the core. This chart illustrates kind of the point that I was making. It lists the different types of nerve fibers and their functions, but more importantly, the differential rate of nerve blockade and recovery that's expected from local anesthetic administration. So as we discussed earlier, smaller diameter nerve fibers and myelinated fibers are more susceptible to local anesthetic action due to a decreased surface area block of voltage-gated sodium channels that's required to effectively inhibit nerve impulse conduction. Therefore, nerve block onset affects sympathetic fibers first, followed by pain and temperature sensation, then touch and proprioceptive input, and finally motor output. And then the nerve block recovery occurs in the reverse pattern. Local anesthetics have various pharmacologic properties that are worth mentioning that affect clinically relevant factors such as time of onset, potency, and duration of action. Bear with me, this is probably the most painful slide of the entire lecture, but we'll get through it as quick as possible. So the local anesthetic properties that are relevant are the pKa, the lipophilicity, or the lipid solubility as it's also known, and then the percent protein binding. And these physicochemical properties affect the onset of action, the potency, and the duration of action respectively. So the pKa of a local anesthetic is the pH at which the molecule exists in equal concentrations of its unionized lipophilic form and its ionized hydrophilic form. The unionized form, as we've talked about, is the one that permeates the neuronal phospholipid bilayer, while the ionized form is responsible for blocking the voltage-gated sodium channel on the cytoplasmic side. And if you take my word for it, the lower the pKa of the local anesthetic, the more it will exist in the unionized form, and the more of it will be able to cross the neuronal membrane, and therefore it'll have a faster onset of action. Since all local anesthetic pKa's are actually greater than the physiologic pH of 7.4, they all exist in greater than 50% of the ionized form. The lipophilicity actually also influences the time of onset. The more lipophilic a local anesthetic, the slower the onset of action, and this is due to impeded dispersion through tissue fluids and sequestration in neighboring adipose tissue or myelin sheaths. Local anesthetic potency, on the other hand, is determined by the lipophilicity. So more lipophilic local anesthetics exhibit increased potency because they basically are a less concentration is required to produce an adequate block because they're more readily able to cross the neuronal membrane and act on the voltage-gated sodium channels. The duration of action of a local anesthetic is largely influenced by percent protein binding and lipophilicity, as well as the presence of a vasoconstrictor. So the percent of circulating local anesthetic drug that is bound to a protein, such as albumin or alpha-1 globulin, has been found to correlate with anesthetic affinity for voltage-gated sodium channels. Greater protein affinity means longer association time of the local anesthetic with the channel itself, and therefore a longer blockade. Furthermore, the longer the local anesthetic remains in close proximity to neural fibers, the longer the duration of action. So more lipophilic local anesthetics produce longer blocks because they sequester in the adipose tissue and the myelin sheaths that surround these peripheral nerves. And so they're very close to being able to diffuse and act on the channels. And then lastly, the presence of a vasoconstrictor such as epinephrine, as we all know, prolongs the local anesthetic duration of action, and it actually prolongs it by about 30 to 50%. And this is because it reduces the rate of vascular absorption of the local anesthetic and allows it to stick around longer. As a general rule of thumb, the heavier the local anesthetic, the more lipophilic it is, and the higher degree of protein binding that it exhibits, the longer the duration of action, potency, and toxicity. And the reverse is true for speed of onset. This table depicts the physicochemical properties of clinically used local anesthetics that we have at our disposal. And as we talked about on the slide prior, the pKa and the lipid solubility primarily determine the onset of action, the time to onset, how fast the local anesthetic will act. The lipid solubility primarily determines the potency of the anesthetic, and then the percent protein binding along with the lipid solubility primarily determine the duration of action, so how long the local anesthetic will act. I want to draw your attention to two amides, bupivacaine and ropivacaine, that are commonly used in hip blocks. The reason they're commonly used is you can see that they have high degrees of lipid solubility and protein binding, which means that they're going to have significant durations of action, so they last a long time. Also, given their high degree of lipid solubility, they're very potent, meaning that low concentrations can be used to adequately anesthetize the peripheral nerves. Both of these factors contribute to why they're ideal for hip blocks. These patients are sitting around in pain for hours, potentially waiting on surgical fixation, and we need to have a long-acting, highly potent local anesthetic on board to adequately anesthetize the nociceptive fibers and the peripheral nerves that innervate the hip capsule. So selection. How do we choose a local anesthetic? Well, it's all about duration of action, okay? I don't really care how fast the onset is. They're all relatively comparable. But I do care about how long it's going to be in their system. So things like for hip blocks, 0.5% ropivacaine or bupivacaine, you can expect that to last, about 10 hours. The anesthesia will last shorter than the analgesia, okay? But if we can get them, to not have pain, I mean, that's really the point of these blocks, right? So, 5 to 12 hours and 6 to 30 hours versus, these shorter acting agents like lidocaine and mepivacaine, which are intermediate block local anesthetics. We're going to use ropivacaine and bupivacaine for these, for hip block indications. For something like a shoulder reduction, chloroprocaine is a great choice. 3% is a high concentration for this anesthetic, so it'll provide a really rapid onset, 6 to 12 minutes, and then chloroprocaine is rapidly metabolized, so it only lasts for about half an hour to an hour, which is great for this indication of a shoulder reduction. If you're going to do a interscalene brachial plexus block for analgesia and someone that needs a shoulder reduction because it's been dislocated, this is a great anesthetic to choose for that. And then we have to talk about maximum dosing. These maximum doses are in place for a reason. It's to help prevent local anesthetic systemic toxicity. So you should follow these guidelines religiously. Adding epinephrine to these local anesthetics increases their duration of action, but it also increases the max dose that you can use because epinephrine decreases the rate of systemic absorption, and therefore you lower the risk of toxicity when you have it on board. Chloroprocaine, like we talked about, can be used in super high concentrations because it's rapidly metabolized. Ropivacaine and bupivacaine are super potent, so we don't need really high concentrations to produce a big effect. So those tend to be smaller doses. And then actually, interestingly, ropivacaine is a vasoconstrictor, so adding epi doesn't really do anything to the max dose. So that's why that's a dash. So we can kind of compare, we've been doing that a little bit, but just to drive the point home, we can kind of compare the local anesthetics that we have available to us now that we know about their physicochemical properties and the three clinical properties that we care about, being the time of onset, so how fast it works, the potency, and the duration of action. So 2-chloroprocaine is the most rapidly metabolized local anesthetic. It's fast onset and has a super short duration of action, 60 to 90 minutes. So the perfect application, like we talked about, is shoulder reduction. So like an interscalene or supraclavicular, infraclavicular brachial plexus block is something that would be great for 2-chloroprocaine. Lidocaine and mepivacaine are intermediate acting and intermediate onset duration anesthetics. So lidocaine will give you about 3 hours duration of action, whereas 2% mepivacaine gives you about 3 to 6. So mepivacaine is great for something, if you're going to be delayed, if your consultants are going to be delayed coming to the patient to, fix a complicated laceration or something, this is a good anesthetic to provide intermediate blockade. Bupivacaine and ropivacaine are your long-acting, highly potent local anesthetics. So bupivacaine is slow onset, longest block duration of all the ones that we have available, but it also has the greatest cardiotoxicity profile, which is why ropivacaine is actually becoming more favored. It's an S enantiomer instead of a racemic mixture, so it has less cardiotoxicity than bupivacaine, slightly less potent and slower uptake, but it has a long duration of action up to 12 hours. And it actually provides a more selective sensory blockade because it's slightly less lipophilic, so it doesn't penetrate down to the motor fibers of the peripheral nerve as readily as bupivacaine. So it's supposed to be provide more of a dense sensory blockade. That's selective, which is another advantage. The most feared and devastating complication of performing ultrasound-guided nerve blocks is local anesthetic systemic toxicity, or LAST. LAST is a dose-dependent progressive clinical syndrome of central nervous system to cardiovascular system toxicity, most commonly caused by accidental or inadvertent intravascular injection of local anesthetic, but can also be caused by excessive dosing. So you're just, you redose the patient without the prior dosing having a chance to have worn off. or it can happen from rapid absorption from hypervascular tissue injection sites, where the local anesthetic is just rapidly absorbed due to the nature of having a significant vasculature at the site. The CNS is more sensitive to local anesthetic toxicity than the cardiovascular system. Therefore, the central nervous system symptoms typically precede the cardiovascular symptoms. Prodromal symptoms of LAST include perioral paresthesias, metallic taste, or tinnitus, and this will precede the development of seizures, agitation, or loss of consciousness. And as the plasma levels increase further, CNS depression will occur, resulting in coma or respiratory arrest. And then the cardiovascular toxicity during LAST is typically characterized by conduction abnormalities, myocardial contractility impairment, and reduction in systemic vascular resistance. You can see cardiotoxicity take effect with early onset EKG findings, including PR and Q2C prolongation, alterations in the QRS morphology, such as bundle branch blocks, and ST interval changes as well. You can also have development of refractory brady or tachyarrhythmias, depression of intrinsic spontaneous pacemaker activity that can rapidly deteriorate to high-grade AV block or even asystole. And then the worst possible thing is, cardiogenic shock and refractory hypotension can also ensue. So, I mean, the spectrum of, what this syndrome can be is vast. And it's important to recognize that the spectrum of signs and symptoms can be present in any combination, and it can progress very rapidly. I want to highlight that approximately 40% of LAST cases present as a sudden onset seizure progressing to cardiac arrest. With large doses of local anesthetic or direct intravascular injection, the CNS symptoms can be absent entirely, and the first manifestation could be, a cardiovascular toxicity. This occurs in about 11% of cases. The rescue therapy is intralipid 20% emulsion IV. This is the LAST management algorithm. So first and foremost, you need to have a high clinical suspicion and be able to recognize the signs and symptoms of local anesthetic systemic toxicity. And if a patient develops any of the LAST symptomatology, you should immediately stop the local anesthetic injection and call for help. So the symptoms that you should be on the lookout for and they should counsel your patients on are, any perioral paresthesia, tinnitus, change in mental status, loss of consciousness, and the more worrisome ones are seizures, brady or tachyarrhythmia, conduction block, asystole. All these things are not, explained by anything else in the context of an ultrasound-guided nerve block than LAST, and they should be addressed immediately. Some key management points that we need to talk about. Airway management and oxygenation are paramount. Oxygen administration should be started early because hypoxia potentiates local anesthetic toxicity. Seizures in the context of LAST should be treated with benzodiazepines, just like in any other seizure disorder. Benzodiazepines are first line, or you can use a small dose of propofol titrated to avoid hypotension. Impending cardiovascular collapse can be heralded by a worsening tachy or bradyarrhythmia or a new heart block. And that's an important thing to recognize, is that if any sort of cardiovascular toxicity that manifests can herald, future cardiovascular collapse, and an intralipid needs to be administered immediately. Early treatment of LAST with this intralipid IV infusion 20% lipid emulsion is suggested to reduce peak serum levels of local anesthetic and reduce the chance of progressing to cardiovascular collapse. Lipid emulsion is typically started at the first sign of an arrhythmia, prolonged seizure, or rapid clinical deterioration. I personally think we should have a low threshold for starting this rescue therapy. If you develop, or if the patient develops any of the symptoms of LAST, you should consider starting this therapy. Another thing is that if the patient goes into cardiac arrest, performing immediate CPR with high quality chest compressions is imperative, because toxic tissue concentrations of local anesthetic in the brain and heart reducing those levels is dependent on cerebral and coronary blood flow. And so the only way you're going to get that is through doing high quality CPR. The last thing I want to talk about in regards to block basics is ergonomic setup. We should be setting up these nerve block procedures in a way that makes sense and that optimizes performance. So as with any procedure that's sterile, you want to expose, the minimum amount of field that's necessary for landmark identification. And then in regards to ultrasound-guided nerve blocks, you want to position the ultrasound machine opposite the side of block performance in an optimal line of sight that prevents provider head movement or discomfort while performing the block. As illustrated in the picture, the optimal setup is provider probe ultrasound machine. We finally made it to the point where we're ready to talk about actually performing these hip blocks. So we'll dive into two common hip blocks that are used in clinical practice: the fascia iliaca compartment block and the pericapsular nerve group or PENG block. We'll start with covering the fascia iliaca compartment block, the FICB. The goal of the fascia iliaca compartment block is to anesthetize the nerves of the lumbar plexus under the fascia iliaca at the level of the inguinal ligament. These nerves are the femoral and lateral femoral cutaneous nerves. Indications include hip and femur fractures, anterior thigh abscesses that are going to require incision and drainage, and then burns over the lower extremity. Contraindications are similar for any ultrasound-guided nerve block and include any local anesthetic allergy, local infection at the injection site, anticoagulation, which is kind of a relative contraindication, coagulopathy, a patient that cannot give consent or that lacks capacity, and then any severe, decompensated psychiatric illness. So a patient that's agitated or acutely psychotic would not be a good patient to stab a needle into. Overall, the complication rates for the fascia iliaca compartment block are low. Hematoma at the injection site location is the most common complication. Infection is low risk as sterile technique is followed. Bleeding is generally minimal if it occurs at all. Neurovascular injury can occur with inadvertent needle puncture of the femoral nerve, artery, or vein. However, the distance at which the skin is punctured from the neurovascular bundle minimizes the risk of neurovascular injury. Furthermore, fascial plane blocks are lower risk as the target injection site is relatively distant from the femoral nerve and vessels. Last is the most feared and devastating complication that we worry about, though it's rare if dosing recommendations and proper ultrasound-guided nerve block performance technique is followed. For the FICB, the provider should utilize the high-frequency linear probe and a 50 to 100 millimeter 20 to 22 gauge echogenic block needle. I typically use the 100 millimeter 22 gauge needle when performing this block. The FICB is also a high volume block, and 20 to 30 milliliters of 0.5% bupivacaine or ropivacaine and 10 milliliters of normal saline is appropriate for long duration analgesia. This slide illustrates the pertinent anatomy that's necessary to know prior to performing a fascia iliaca compartment block. We'll pull out the laser pointer so that we can go over the pertinent anatomy together. The fascia iliaca seen here covers the iliaca muscle throughout its descent from the iliac crest into the upper thigh, and it merges medially with the psoas fascia overlying the psoas muscle. The femoral nerve arises from the L2 to L4 nerve roots, and the lateral femoral cutaneous nerve arises from the L2 to L3 nerve roots, and they emerge from the lateral border of the psoas muscle and travel underneath the fascia iliaca as they descend over the ventral surface of the iliacus muscle in their intrapelvic and inguinal course. The articular branches of the femoral nerve arise proximal and distal to the inguinal ligament to provide innervation to the anterolateral hip capsule. The obturator nerve arises from the L2 to L4 nerve roots, and it comes or emerges from the medial border of the psoas muscle and travels posteriorly behind the common iliac vessels towards the obturator foramen. It's separated from the fascia iliaca by the psoas muscle and therefore is not consistently blocked by the fascia iliaca compartment block. The articular fibers of the obturator nerve arise before passing the obturator foramen to supply the inframedial aspect of the hip capsule. And then when the accessory obturator nerve is present in about 10 to 50% of patients, it leaves the obturator nerve proximally and emerges from the medial border of the psoas muscle to cross over the superior pubic ramus, where it supplies the anteromedial aspect of the hip capsule. So kind of in summary, the hip capsule is innervated by the articular fibers arising from the femoral nerve, the obturator nerve, and when present, the accessory obturator nerve. There are two general techniques or approaches that can be used to perform the fascia iliaca compartment block, and they are the suprainguinal and infrainguinal approach. The FICB has evolved over time from the infrainguinal classic approach to the more novel suprainguinal technique with the aim to spread the local anesthetic injection cranially. This more consistently reaches the lumbar plexus with superior efficacy compared to the infrainguinal approach. The efficacy of the FICB assumes that the injection of local anesthetic beneath the fascia iliaca reaches the femoral nerve, the lateral femorocutaneous nerve, and eventually the obturator nerve proximally, although an obturator nerve block is not consistent. We're going to focus more on the classic infrainguinal approach, though for completeness sake, we will cover the suprainguinal approach as well. This slide illustrates the suprainguinal approach to performing the fascia iliaca compartment block. You want to start by palpating the anterior superior iliac spine, the ASIS, and you want to place the linear array transducer medial to it in a sagittal plane perpendicular to the inguinal ligament. Phrased another way, the probe is often rotated slightly clockwise from the parasagittal orientation so that it is perpendicular to the inguinal ligament. And you can see in the picture on the left how the provider has the probe medial to the ASIS and in a parasagittal orientation to where it's perpendicular to where the inguinal ligament would run. You want to slide the transducer caudally and medially along the inguinal ligament until the triangle shape of the anterior inferior iliac spine, the AIIS, is visualized as a hyperechoic outline deep to the iliopsoas muscle. Superficially, the sartorius muscle is going to be seen lateral, and the internal oblique muscle will be seen medially, forming a characteristic bow tie image on ultrasound. The sartorius muscle and the internal oblique muscle form the bows of the bow tie, and the fascia iliaca is the tapered portion of the bow tie. You want to be aware of the deep circumflex iliac artery and its location when performing this block. The needle is typically inserted using an in-plane technique from lateral to medial, and local anesthetic is spread in plane between the iliopsoas muscle and the fascia iliaca. The deep circumflex iliac artery is often seen displaced anteriorly with injection, and this is used to confirm that you're in the right plane while injecting local anesthetic. The infrainguinal approach to the fascia iliaca compartment block is the more classic teaching, and it's what we typically perform in our emergency department for hip blocks. The linear array transducer is placed in a transverse orientation at the femoral crease, distal to the inguinal ligament. You can see in the picture on the left that the provider has the probe in the inguinal crease with a slightly transverse oblique orientation. The provider should try to identify the femoral vein and artery, the iliopsoas muscle, and the fascia iliaca on the ultrasound image. Tilting and applying pressure to the transducer can help to identify the hyperechoic fascia iliaca overlying the hypoechoic iliopsoas muscle. The femoral nerve lies deep to the fascia iliaca and lateral to the femoral artery. The transducer is then moved laterally until the sartorius muscle is identified by its typical triangle shape, and the needle is going to be inserted in plane, lateral to medial, often through the sartorius muscle. You want to advance it toward the fascia iliaca several centimeters away from the femoral artery. 2 pops should be felt as the needle punctures the superficial fascia lata and then the deep fascia iliaca. The fascia may be seen snapping back on the ultrasound image during the puncture. And then after negative aspiration, 1 to 5 milliliters of normal saline can be injected to confirm proper plane of injection. Injectate should layer out from medial to lateral as an anechoic fluid spread, resulting in separation of the fascia iliaca from the iliopsoas muscle. And then once you have confirmed that you're in the right plane of injection, you can switch to local anesthetic and inject 20 to 40 milliliters and confirm that it's spreading in plane between the fascia iliaca and the iliopsoas muscle as it approaches the femoral nerve medially. This slide illustrates the proper probe positioning and the relevant sonoanatomy that you should be visualizing when performing the infrainguinal fascia iliaca compartment block. The linear ray transducer is placed within the femoral crease in a transverse orientation. The needle insertion angle is approximately 30 degrees from the horizontal. The corresponding sonoanatomy shows the femoral vein, artery, and nerve from medial to lateral as we go through the clip. For anatomic orientation, remember venous to penis, as the femoral vein is the most medial structure. One can also see the hypoechoic iliacus muscle with 2 overlying hyperechoic stripes corresponding to the superficial fascia lata and the deep fascia iliaca that is just above the iliacus muscle. In the far field, the psoas muscle can be appreciated with the hyperechoic psoas tendon just above the iliopsoas notch of the iliopubic rim. Here is a side-by-side comparison of the relevant sonoanatomy of the infrainguinal fascia iliaca compartment block. The labeled version is on the right for easier identification, compared to the unlabeled version on the left. I'd like you to familiarize yourself with what you should be viewing to adequately perform this block. After performing a fascia iliaca compartment block, the local anesthetic has an expected dermatomal, myotomal, and osteotomal block distribution that's pretty consistent across each block that's performed. The dermatomal distribution covers the lateral femoral cutaneous nerve, the femoral nerve, and the saphenous nerve, extending from the anterolateral thigh to the medial leg and ankle. The myotomal distribution is purely from blockade of the femoral nerve, as the lateral femoral cutaneous and saphenous nerves are purely sensory in function. Motor blockade results in quadriceps femoris muscle weakness. Therefore, the patient's going to have the inability to extend the leg at the knee joint. The osteotomal block covers the entire length of the femur, including the head, the neck, and the diaphysis. It also includes the patella, the proximal medial tibia, and the medial malleolus. The second hip block we're going to talk about is called the pericapsular nerve group block, or the PENG block, PENG. The PENG block was originally developed from a search for alternative nerve block techniques to provide selective articular sensory block of the hip. It was originally developed in 2018, and it has provided excellent results. So far, the literature shows that the PENG block provides superior analgesia compared to the femoral nerve block and the fascia iliaca compartment block, with the added benefit of being a motor sparing block. And that last part is huge. The fact that you can spare motor impairment using the PENG block allows for these traumatic hip fracture patients post-surgery to participate in physical therapy and actually ambulate, which is a tremendous accomplishment, because a lot of the morbidity that's associated with hip fractures is due to the fact that these patients can't ambulate from pain. And if we can improve their pain scales and allow them to ambulate immediately post-surgery, this is a great innovative block that we should be utilizing. The goal of the PENG block is to block the sensory nociceptive articular fibers that innervate the hip capsule as they run over the iliopubic rim deep to the psoas fascia. The indications include proximal hip fractures, so subcapsular transverse femoral neck or intertrochanteric hip fractures, acetabular fractures, and pubic rami fractures. Contraindications to block performance again, are local anesthetic, allergy, infection over the injection site, anticoagulation or coagulopathy, a patient that can't consent, and then patients who are crazy, agitated, psychotic. Those are patients that you should not be doing this procedure on. Just like with the FICB, the complication rates for the PENG block are generally speaking very low. Hematoma at the injection site location can occur. Infection is a low risk complication as we should be doing this procedure sterilely. Bleeding is generally minimal if it occurs at all. Neurovascular injury can occur. In particular, the lateral femoral cutaneous nerve is vulnerable to injury due to its superficial location, lateral to the transducer, and close to where we're going to be inserting the needle through the skin. Last is the most feared and devastating complication, though it's rare if you're following max dosing recommendations and proper performance technique. For the PENG block, the provider should utilize the high-frequency linear probe in low BMI patients, but generally speaking, the low-frequency curvilinear probe is going to be required due to the depth of the injection target, especially in large BMI patients with a plethora of subcutaneous tissue. An 80 to 100 millimeter 22 gauge echogenic block needle should be utilized. I typically use the 100 millimeter length when performing this block in the emergency department. The PENG block is a high volume block, and 20 to 30 milliliters of 0.5% bupivacaine or 0.5% ropivacaine in 10 milliliters of normal saline is appropriate for long duration analgesia. This figure highlights the pertinent anatomy that's imperative to know prior to performing the PENG block. I'm going to pull up the laser pointer again to go over the anatomy with you. The PENG block targets the nociceptive articular fibers that innervate the anterior surface of the hip capsule, and they're located here. In contrast, and interestingly, the posterior hip capsule primarily contains proprioceptive fibers, and I think that's kind of interesting microanatomy that was discovered, relatively recently. That the anterior hip capsule is primarily nociceptive fiber innervated, while proprioception fibers tend to innervate the posterior hip capsule and are responsible for allowing us to know our hips orientation, the femur's orientation in space. The articular innervation of the anterior hip capsule is composed of branches from the femoral nerve, located right underneath the fascia iliaca, lateral to the femoral artery. The obturator nerve, which is going to be coming from the obturator foramen medially, and the accessory obturator nerve, which runs over the superior pubic ramus, located right here. The articular branches of the femoral nerve actually travel over the surface of the iliopsoas notch right here. And the iliopsoas notch is located between the anterior inferior iliac spine and the iliopubic eminence, located just deep to the femoral artery and vein. These fibers reach the plane between the iliopsoas muscle and the iliofemoral ligament and innervate the anterolateral aspect of the hip capsule. The articular branches of the obturator nerve exit the pelvis through the obturator foramen, and they actually travel between the pectineus muscle and the obturator externus muscle that aren't shown here, and they innervate the inferior medial aspect of the hip capsule. The accessory obturator nerve, when present in about 10 to 50% of patients, travels deep to the psoas muscle and over the superior pubic ramus to supply the anteromedial aspect of the hip capsule. And the PENG block provides a pretty consistent block of the articular branches of the femoral nerve and the accessory obturator nerve. Studies in cadavers have actually demonstrated, using dye as an injection media, it's demonstrated that the obturator nerve is actually covered pretty reliably. So the PENG block is heralded as a predominantly sensory nociceptive fiber block of the hip capsule with a motor sparing component, and it has been demonstrated to reliably anesthetize the articular fibers of all three nerves that innervate the hip capsule, being the femoral nerve, the accessory obturator nerve, and the obturator nerve. This figure illustrates the various transducer positions that can be utilized to perform a hip block. The pericapsular nerve group block is depicted in panel A, and it's showing the probe oriented in a transverse oblique fashion in plane with the iliopubic rim. So this is what how your probe should be oriented when performing the PENG block. This figure illustrates the general approach to performing the PENG block. So to start out, you want to place the curvilinear or linear array transducer over the femoral crease in the transverse oblique orientation, which is about 45 degrees rotated from the transverse plane. You want to be parallel to the inguinal ligament, and you want to start by imaging the femoral head, which is going to appear in the far field as a hyperechoic curved stripe with posterior acoustic shadowing. You also want to make sure that you have the femoral artery in view while visualizing the femoral head. Keeping the femoral artery in view, you want to slide your probe cranially along its short axis until the hyperechoic iliopubic rim becomes visualized. You should be able to identify the hyperechoic iliopsoas notch between the AIIS laterally and the iliopubic eminence, the IPE, more medially. And the hyperechoic psoas tendon should be directly overlying the iliopsoas notch. The needle is going to be inserted in plane, lateral to medial, through the iliopsoas muscle as depicted in this image on the right. And you're going to approach the psoas tendon, and you want to put the needle tip just lateral and deep to the psoas tendon in the iliopsoas notch. And you're going to use the iliopsoas notch as a bony backstop. And once you hit the bone, you're going to twist and rotate the needle in your hand just ever so slightly to assist you with penetrating the psoas fascia, because we want to pop through the fascia to anesthetize the nerves that are the articular fibers that are located underneath it. After negative aspiration, you're going to inject about 10 milliliters of normal saline just to confirm that you're in the proper plane of injection. Injectate should layer out with medial to lateral spread of anechoic fluid, resulting in elevation of the psoas tendon and psoas muscle off of the iliopubic rim. And that's how you confirm that you're in the right plane. Once you've done that, you can switch to local anesthetic and inject 20 to 40 milliliters and confirm that it's spreading between the psoas fascia and the iliopubic rim. And that's a successful PENG block. This slide illustrates the proper probe positioning and the relevant sonoanatomy that should be visualized when performing the PENG block. The linear array transducer is placed within the femoral crease in a transverse oblique orientation, which is about 45 degrees rotated from the transverse plane. The needle insertion angle for the PENG block is rather steep at about 60 degrees from the horizontal when compared to the 30-degree insertion angle of the Fascia iliaca compartment block. The corresponding sonoanatomy clip initially shows the femoral head in the far field with the readily identifiable femoral artery in the medial near field. As the transducer is moved cranially, the iliopubic rim is brought into view as a hyperechoic undulating stripe. One can also see the hypoechoic iliacus muscle with two overlying hyperechoic stripes corresponding to the superficial fascia lata and the deep fascia iliaca. In the far field, the psoas muscle can be appreciated with the hyperechoic psoas tendon just above the iliopsoas notch of the iliopubic rim. Medially, below the femoral artery is the iliopubic eminence. As the video clip moves laterally, the anterior-inferior iliac spine is visualized. And the injection target for the PENG block is located just lateral and deep to the psoas tendon within the iliopsoas notch. Not to belabor the point, but I just want to make sure we know how to properly acquire the optimal ultrasound image for PENG block performance. So starting with the image on the left, we are going to first place our ultrasound transducer at the level of the femoral head within the femoral crease at point A. And keeping a transverse oblique orientation, we're going to slide the transducer cranially along its short axis to line B. This will bring the iliopubic rim into visualization. Once we see the hyperechoic undulating iliopubic rim, we should be able to visualize the hyperechoic psoas tendon just above the iliopsoas notch. And the injection site target for the PENG block is just lateral and deep to the psoas tendon within the iliopsoas notch. The sonoanatomy clip on the right has been labeled for easier identification of the relevant anatomy structures. Here is a side-by-side comparison of the relevant sonoanatomy of the PENG block. On the right is a labeled version for easier identification as compared to the left, which is unlabeled. I would like for you to familiarize yourself with what you should be viewing to adequately perform this block. The last couple slides of this presentation depict an actual PENG block performed in our emergency department for an elderly woman who suffered a ground level fall with a left transverse femoral neck fracture. A curvilinear probe was used to perform this block due to the patient's body habitus. This slide depicts the relevant anatomy again for review. You should practice visualizing the anatomy in the unlabeled version and using the labeled version for confirmation of knowing which structures are which. You may notice it is slightly harder to identify structures with the low frequency transducer and in someone with less than ideal habitus and anatomy. So this slide depicts the in-plane needle approach down to the iliopsoas notch, just lateral to the psoas tendon. So you can see the hyperechoic needle, going through the iliopsoas muscle down to the iliopsoas notch, just lateral to the psoas tendon. And again, it's kind of hard to see because of the body habitus of the patient and the fact that we're using a curvilinear probe. But you can still make out where the iliopsoas notch is from the fact that we see the iliopubic rim and the AIIS, which is more lateral. Okay, so you're basically just going just medial to the AIIS, hitting the bony backstop, which is the iliopsoas notch, and injecting along that plane, which should push the iliopsoas muscle up along with the psoas tendon, and that'll confirm that we've hit these articular fibers that innervate the hip capsule, okay, the nociceptive fibers that are causing all the pain. This last slide depicts successful local anesthetic deposition underneath the psoas fascia and around the psoas tendon. The surrounding iliopsoas muscle is lifted up by the local anesthetic. 20 milliliters of 0.5% ropivacaine with 10 mLs of normal saline was injected. The patient actually had significant pain relief post-PENG block and did not require opioid pain medication at all overnight, leading up to her surgical fixation the next morning. So if we take a look at the slides again, the unlabeled version, I'll play it here. So we have the iliopubic rim here. We have the local anesthetic that's deposited on either side of the psoas tendon, and you can see it more readily apparent on the labeled version. So local anesthetic being deposited around the psoas tendon. So we know we're in the right plane and that this patient got a successful block. And clinically, she reported no pain. So this is great, great for patient outcome. So I'll leave you with two great apps that I have and that I use frequently for reference when performing ultrasound-guided nerve blocks in the emergency department. Nisora's app is the most practical and authoritative reference guide to ultrasound-guided nerve blocks. And the Nerve Block app is a free open access medical education project that aggregates content from the POCUS Atlas, Denver Ultrasound, WikiEM, and Highland Ultrasound. Both apps are great, and they detail how to perform each ultrasound-guided nerve block, including indications, contraindications, complications, optimal techniques. I mean, they really just detail everything there is to know about how to go about performing these blocks successfully. So I hope you enjoyed this presentation. Reach out to me if you have any questions. And I hope that I have convinced you of the importance of utilizing these techniques, these nerve blocks, for pain management in our patient population at Aventura. Thank you.